de mama. Esta mañana tengo el placer de presentar al profesor Thomas Helbig del Departamento de Imagen Biomédica y Tratamiento Guiado por Imagen de la Universidad de Viena. El doctor Thomas Helbig es uno de los past presidents de USOBI, de la Sociedad Europea de Radiología de Mama, y además es uno de los líderes de los grupos de investigación más potentes que existen no solo hoy en Europa, sino también en el mundo. Él nos va a hablar del potencial de la resonancia magnética, lo que hablábamos ayer, en la valoración de la respuesta a la neoadyuvancia. Professor Helbig, please, you have the floor.
So, good morning, ladies and gentlemen. I will speak very slowly so that the people behind you can translate it in Mexican. So, I will speak about the potentials of MRI in the breast during neoadjuvant chemotherapy. And I promise you, so it's better. I promise you, I have almost 60 minutes. I will not speak 60 minutes about MRI and neoadjuvant chemotherapy. So I prepared also some cases. I do not know how more or less you are familiar with MRI. So maybe you can raise the hand who does already MRI of the breast. Oh, see, it's good. Many? So it may be that the cases I choose for the first lecture are too simple for you, but in the second talk, when I speak about interventional MRI, I have then a lot of other cases. So this is the problem with respect to the organization, that I cannot switch immediately among the cases. So, but let's first speak about the role of MRI. In neoadjuvant chemotherapy, something to disclose, some research grants, and here is already the outline. I will speak about which imaging technique should we use. Of course, you can already imagine that I will speak a lot about MRI, then how we should measure the tumor response. I will then wrap it up as part one, and then in the second part I will speak about how we can use MRI to predict treatment response. So that's something which is challenging, but you can all more or less maybe impress your oncologists when you hear about this. So some words about systemic chemotherapy. We all know that chemotherapy improves breast cancer patients' outcome. It is a standard in high aggressive cancers, most likely in node positive cancers. And with respect to treatment, the oncologists use two terminologies. First, if they give the chemotherapy after surgery, they say adjuvant. If they give the chemotherapy before surgery, they say neoadjuvant chemotherapy, and therefore I will always speak about this NAC, indicating neoadjuvant chemotherapy. And why do they think that neoadjuvant chemotherapy is maybe better? Because they want to monitor the tumor response, and they want to do less mastectomies. They want to preserve the breast. So, however, we learned over the years that the treatment, either adjuvant or neoadjuvant, does not really influence the overall survival. So when you have a look on these curves, on these Kaplan-Meier curves, you see that in both groups, adjuvant and neoadjuvant, the survival rate is almost the same. There are some rumors in the last years and months that neo is a little bit improving, but still these are some very robust data. So, and this brings me now to imaging. So, and which imaging technique should we use? There is a mammography, and you are all experts. Where is the cancer? Right or left? Left. Everyone says it is left, because here something which looks, so we would do an ultrasound. But when I show you the corresponding MRI, you will see that, first of all, we could not see the cancer on mammography, and it is on the right side. And this is indeed a huge advantage of contrast-enhanced MRI, to see cancers which are not seen or not good seen on mammography. So, and over the years we learn that MRI gives a lot of very important information for staging and treatment decisions. Of course, some of you will say, what's about mammography and ultrasound? They are very important primary diagnostic tools. They, however, it is of course clear, if you have such a lot of information on mammography with respect to density, that the lesion is often underestimated on his or its extent. And mammography and ultrasound is not really helpful in tracking tiny little changes. And of course, there are some other negative points with respect to limited in the assessment of minimal residual disease, and they are not as good to predict the risk of recurrence. So, where does this statement come from? There is a lot of studies already published in the last 5-6 years, and I picked some of them to show you that there is indeed evidence that demonstrates that MRI is indeed the most or the best technique if we speak about size assessment. So this is a study it's a meta-analysis. They included 44 studies and 2,050 patients. And what they learned is that MRI is the most accurate technique in comparison to clinical exams and mammography. Of course, MRI or the power of MRI is influenced also by the pathologist. For example, if the pathologists are a little bit, let's say, lazier with respect to the definition of partial complete response, our measurements are no longer as accurate, and therefore also the pathologists have to learn how to judge on complete response assessment. And a lot of people always ask me, what's about ultrasound? That's indeed true. There is, let's say, a limited number of studies which assess ultrasound. And therefore, I want to show you a recent, or more or less two recent meta-analyses. They reviewed 8 studies, and they could again demonstrate, based on the data, that MRI is superior to clinical exam, mammography, and ultrasound, as they now included more ultrasound papers. And indeed, MRI is the most appropriate test for doing this size and chemotherapy assessment. Ultrasound, as you can imagine, particularly if the tumor responds on chemotherapy, always underestimates the size. Nevertheless, there is some, let's say, for those who are doing ultrasound and do think that ultrasound helps in the assessment, there is a recent paper just published which demonstrates that B ultrasound is not good, but if you use contrast-enhanced ultrasound, that it is at least comparable to MRI. It is still weaker in the assessment during or after neoadjuvant chemotherapy, But overall, they say it is at least comparable. Nevertheless, to be honest, if you compare the costs of ultrasound plus using ultrasound with a contrast agent, and you more or less add together the time you are using, the time you are preparing the patient, and, to be honest, even with contrast-enhanced ultrasound, the inter-reader, variability is very high, I would strongly argue to perform a simple MRI, which maybe has the same costs. And this is also represented by a survey which will be published very soon, performed by the European Society of Breast Imaging. They asked, when do you perform MRI? And there you can see such, we call it spider diagrams. And it's very simple to understand. In the center, it's 0%, and the outer line is 100%. And if you have a closer look to this neck number, you see that indeed MRI is already a strong partner if we want to assess neoadjuvant chemotherapy. You see that it is, of course, a little bit more used in university hospitals than in community hospitals, but overall we are close to 80%, which is good. And there is, of course, a difference of those countries who have a lot of MRI machines and those countries who do not have MRIs, and therefore you see that, for example, Eastern European countries cannot perform as much as they would like, but still already do a lot. So what we also learned is that MRI is a really important tool with respect to measure the size of a lesion. There you see that there is a strong correlation, it's about 80%, between what we see and measure on MRI and what is seen on pathology. But we have to be very careful. And this is a case from one of our studies where you see the primary tumor. It is this white tumor on MRI. And after 6 cycles of chemotherapy, you cannot see the tumor anymore. But this does not mean that the patients will not undergo surgery. You still have to perform surgery. Of course, the amount of the tissue taken out is maybe less, but it is always good to perform and at least a little bit of surgery of this area. And therefore it is so important, by the way, and you will hear more about this in my second talk, that whenever you plan neoadjuvant chemotherapy, please, you have to clip the lesion. It's very important because such results may seen in about 30–40%. Depends on the drug, depends on the inclusion. So always place a clip. So we learned now which technique. I'm pretty sure that all of you are now impressed by MRI, and all of you will use MRI. And now we want to teach you how we more or less measure tumor response. First of all, we can do it with clinics, we can do it with different imaging modalities, and of course with pathology. But what all these 3 types of exams have in common is they measure the maximum diameter. It's very simple. And what we have to do, we have to use the RECIST criteria. It stands for Response Evaluation Criteria of Solid Tumors. And I'm pretty sure that all of you are aware. It's almost everywhere the same. If you judge on a lung cancer or if you judge on a prostate cancer, they have these 4 categories. This is complete response, total disappearance, partial response, at degrees of more than 30%, and then progressive disease if the tumor grows, And stable disease is everything between partial response and progressive disease. And I will show some cases. So this is a classical complete response. Okay? Perfect. Nothing is seen. Very simple. So now we led to another case. Again, there you see contrast-enhanced MRI. You see the lesion. This is before contrast media application, also before chemotherapy. There you see the clip. And after neoadjuvant chemotherapy, you see a very impressive size reduction. Okay? You measure this diameter, you measure this diameter, and very simple, of course, based on these measurements, more than 30%, it is partial response. Very simple. So let's now head to progressive disease. Also very simple. If something is increasing in size, here, for example, this is the baseline, this is after 3 cycles, we have to tell you already, the surgeon and oncologist, please, this tumor is growing, change to another treatment. And stable disease, this is a nice case of stable disease, as told, everything between progressive and partial response. So you see here the cancer on the right breast, a huge one, and it is a little bit responding, but not much. Again, you measure the largest diameter and you give your answer. So, very simple. So, I'm now happy that we are already at the end of part 1. I just told you how to measure, which technique, and I also want now to conclude on the aspects of MRI. What we just did together is, of course, very helpful for the oncologists and the surgeons. They can decide based on our information if they want to do breast conserving therapy or they want to do mastectomy. However, if we use such a super tool like MRI, we should more or less raise the question, is there not a chance, if we use MRI, that we can predict the outcome of neoadjuvant chemotherapy? To predict the outcome, that means we use MRI and tell the oncologists, based on the imaging, I predict that this will be a responder. I will predict that this will be a non-responder. And I will show you now how you can impress your oncologists starting with Monday. Okay? On Monday, you demonstrate when you have the next tumor board how MRI can predict tumor response. And I start very simple. I start with a standard contrast-enhanced MRI and will then go to advanced techniques which are a little bit futuristic or fancy, but let's do it together. So, if you have a standard contrast-enhanced MRI, there are 2 main indicators for treatment response. One is morphology, very simple, and one is tumor size. So, an old but a very helpful paper, already 15, 16 years ago, Eserman from San Francisco published this paper, and it's indeed very helpful. If you have a tumor which is usually solid and, let's say, round, let's say it's a mass, yeah? Or microlobulated, these lesions always respond best. However, if you have such like this one, or like that one. However, if you have a tumor which is more like a non-mass enhancement, or a mass which is really hard to define the borders, they always respond very poorly. So from Monday on, if you see a rather round cancer, you say, if you want to do chemotherapy, I promise you that this will respond very well. And in addition to that, a simple size measurement between first therapy and second and first control is also helpful. If there is a decrease in size, we know already that among, let's say in 80%, they respond very well. No decrease, respond very poorly. So, nevertheless, we said, currently we do at least a treatment for 3 cycles. Usually it's about 3 months. And if we do not see, and based on these 3 months, we judge then if we want to change to treatment or not. But still, size is important and helpful. And there is a very important paper from an ACRIN trial, which was published 3, 4, 5 years ago, and they underpowered and underlined our statement with respect to size measurement. The change in breast tumor size at MRI can be assessed better in comparison to clinical assessment, and there you see the super numbers for MRI in comparison to clinical exam. But it also seems that if you calculate the volume, it is better than the diameter. So what I could recommend, always try at least to assess the volume based on your 3 measurements, 3 diameters. And what we learn is that, of course, the prediction of complete response or partial complete response is always better with MRI. And that's the reason, and they conclude already that, as I said, we can use this information as a predictor of treatment response. And the good thing is that whenever you make these changes, make these measurements, it is true for all parts of your chemotherapy cycles, at the beginning, at the mid, and at the end. Volumetric measurement, you see this is the orange line, is always much, much better than clinical size assessment or even diameters. But when you're sitting in the tumor board and discussing the cases with your oncologists, you have to notice some information which I will now present to you. It has something to do with tumor biology. These are 2 different cases. A woman with a cancer in the first row and the next woman with a second row, okay? So let's go through this case. There is a huge enhancement. We do the control scan. We see no enhancement. And everyone would say, this is at least partial complete response because I cannot see anything. Let's do the next case. Huge area. It is shrinking. It is more shrinking. I would say at least more than 30, 40, 50%. It's tiny. MRI says partial response. But pathology says no response. What happened? And this has something to do. This is a HER2 positive cancer, and this is a HER2 negative. So, and this you have to take into your account. If the cancer is HER2 positive, we know that the correlation with MRI is always superb. However, if it's negative, we are not so good. And the same is true if Ki67, it's a proliferation marker, is high, you have a low size discrepancy. So, HER2 positive, Ki67 high, then you are really good with MRI. And this has just been, supported by a recent published paper where they say MRI predicts pathologic complete response in HER2-positive breast cancer after neoadjuvant chemotherapy. You see, it takes some time. There is one group who says this, let's say in 2012, and others follow, and the good thing is that they more or less see the same. But with these simple tools, there is also a very important next step possible. And I want to show you some very recent publication which has something to do with machine learning, big data. So, the group of UK did, based on the morphology images, on T2 weighted images, they used of course T1 and correlated with T2, a so-called texture analysis feature, and they showed very promising result because these texture changes are associated with the tumor heterogeneity. And this is very helpful, and this is a very strong and powerful predictor of partial complete response. You see the numbers, depending what you include, 80 to 100%. So this is really helpful if you have more or less a tool, a computer, which gives you already, based on simple, it's not simple, but it's very tricky to do this, but let's say rather simple algorithm which helps you to predict tumor response. So, you just learned that a simple contrast-enhanced MRI, without looking at any curve, without doing something fancy, can help you to predict treatment response based on morphologic findings and based on size and volumetric changes. In the last 5 minutes, I will now focus on advanced techniques. Maybe techniques which you can not easy implement, but they are available, and they should, of course, impress you. First, some words about, which is simple already, contrast-enhanced kinetics. We all know that if you inject a contrast agent, the reason why we see this contrast agent in the tumor is associated with tumor angiogenesis. So, the reason of neoadjuvant chemotherapy is to impact this angiogenesis. So, what some of the drugs want to induce is no translation. Okay, so okay. So you can, that these drugs more or less obliterate the vessels, and then you have a chance. And you can measure this. This is the curve before treatment, and this is the curve after treatment. You see, it collapses, it changes. Simple. But if you do this, then you have to use so-called permeability measurement maps. They are now available in almost all workstations. And there you see how it could potentially work. They give you usually parameters, imaging biomarkers, which are related to the permeability of a tumor. This is usually said K-trans, and of course also the extracellular volume. And what you can create are so-called color maps. Color maps, you know, at the beginning of the therapy and at the end of the therapy, there you see already on contrast that, as I promised, this is a rather round tumor. It shrinks much better than this rather big non-mass enhancement. Yeah? But the beauty on these permeability and color maps is that based on the colors and on your imaging biomarkers, you can already predict, based on these numbers, that this will be a responder versus this will be a non-responder. And more work is, of course, invested. In addition, what we also learned is that if we use these permeability maps, which is done by the computers, that 2 bioimaging markers can already predict the outcome of a patient. So, if, for example, you give a treatment and the tumor is still big in size, and your enhancement / permeability measure is strong, this is a sign for a very worse prognosis. And we can see this on these Kaplan-Meier curves, that this patient live not as long as the others. So that's also important for us to demonstrate the oncologists that there are imaging biomarkers available, because this group of patients has to be treated in a different way. So the best would be to stop the treatment already after 1 cycle of chemotherapy and give them a complete other treatment. And I will also start a little bit about a very interesting and very promising technique. I mentioned this already in one of my first talks, that there is now a paper published which says that the combination of contrast-enhanced MRI and diffusion-weighted imaging is also very helpful. Diffusion is easy to implement. It's about a technique which runs no more than 2-3 minutes. We need no contrast agent for the technique by itself. And it more or less measures the movement of the water molecules among the cells. And if the movement of this is very, very fast, it is usually a benign tumor and the apparent diffusion coefficient is high, then the tumor is bright. But in contrast, if the cancer or in a cancer, the movement is very slow and the apparent diffusion coefficient is usually dark. So what you see now in the next images is a dark cancer, okay? So, and there you see how these diffusion-weighted maps work in patients which are under neoadjuvant chemotherapy. As said, you see this dark area. This dark area indicates a cancer. In those who respond, you do not only see a shrinkage of the tumor, but you see also a change in the color. You see from dark to gray, whereas in the non-responder, it is, let's say, still very dark, and the size did not change very much. And why do we see this change in our apparent diffusion coefficient, in our molecular measures, is that the treatment leads to a damage of the cells, and the room between the cells get bigger, and the molecules can start dancing very fast again. And that's the reason why we see it much, much better. And the beauty is that we can already assess these changes before we see any size change after 1 cycle of preoperative chemotherapy. And that's more or less where we want to head. There is another very important and promising study, particularly if you use proton spectroscopy. We all know that in cancers, the choline peak is higher than in benign lesions. And we use them to differentiate benign and malignant lesion, and we can also use them to assess treatment response. And there you see what I want to show you is you have again the cancer, strong enhancing mass, and as we learn already, if you compare only the first 2 cancers, responder, non-responder, this is rather a round-looking mass. As we just heard, it's responding very well. A rather non-mass super enhancement, not very well responding. So morphology helps, but also the information on spectroscopy helps. This is the choline peak. You see huge choline in both cancers. However, in this cancer, which is a responder, it goes down, whereas in this, it still stays. And this information, in contrast to angiogenesis measures or diffusion-weighted measures, can already be done and can predict already treatment changes after 24 hours after onset of the treatment. That means you give a treatment and do the MRI scan 1 day later, and you can already predict if the tumor will respond or not. And that's the reason where so much work and effort and research is done in this field. And that's a nice chart which demonstrates what I just told you. These are the graphs for the MR spectroscopy. This is the baseline, and in all, you see that the number of choline goes down. There is only one exception. Okay? As it is a line like this. If you do the measurement with your ruler, you see that more lines go parallel. So we see the effect with the size measurement much, much later than with the measurement of choline. Nevertheless, we have to acknowledge, and this is a paper which has been published recently, that MRI spectroscopy is super, but if it is done in a multicentric approach, it is not simple. And even expert centers in the States had technical difficulties to acquire MR spectroscopy data. And this is more or less the message of the paper is MRI spectroscopy is good, but we have to improve, you know, the reproducibility of these measurements, the technique, and then it could be a very potential and powerful tool. So, but when we speak about MRI, we are not far away from hybrid scanners with PET. So some words about nuclear medicine, as this is a booming field and we are coming closer, the nuclear medicine physicians and the radiologists, so that you can also hear some word about the use of nuclear medicine in treatment response and prediction. These are, you know, I'm pretty sure that you are familiar with these PET-CT images, and there you can see the uptake of a cancer in a breast. Very easy to see because it is lightening up. This is the FDG uptake. But what we learned is that also nuclear medicine can predict tumor response or not if, it's very simple, if the FDG uptake is always high, even in the second week of the neoadjuvant chemotherapy setting, it is almost always a non-responder or a weak responding tumor. However, if you see already, let's say, decrease of the uptake of FDG in the second week, you can predict that this is a very good responder. But in addition to this very simple application of FDG PET, nuclear medicine has a lot of super tracers coming, which are much more specific than any of our contrast agents with respect to hypoxia of tumors, of apoptosis, of hormonal receptor status. Therefore, I do think that's so important that we come closer. And here is a very important, nice study where they used a FMESO. This is a hypoxia tracer, and this hypoxia tracer performing PET-CT can already be used to predict primary endocrine resistance in estrogen positive cancer. This is where we want to go. And I show you what you see and the difference you see when you perform FDG PET and FMESO PET in one and the same patient. You see it already on the colors. In FDG, everything is yellow, the whole tumor. But with F-meso, you see that the tumor shows you a tumor heterogeneity, that there are areas which are green, in the center there are areas which are red. And we know this from pathology, that in the center, hypoxia is always higher than in the periphery. And that's seen on this image. So we get more information, and I do think that this is very, very helpful. By the way, this is already a PET MRI of a breast, so this is the next level, where we can then add information on PET and all the information I told you of MRI. And I'm pretty sure that this helps us to go in the direction of P4 medicine in radiology. Many thanks for your attention. Yeah, it's okay. Okay. So now after this, let's say, I don't want to say boring talk after, but it was, I can imagine that a lot of people were waking up very late, had only maybe slept 6 hours because all of you were partying last time, a lot of dancing, there was a good music outside. Some of you had a little bit of too much wine or tequila or whatever. So I'm pretty sure that all of you are, a little bit, let's say, you relaxed, yeah? You enjoyed the talk. So, and now in the next 10-15 minutes, I want to, let's say, motivate you a little bit. You have to actively work now. So I prepared some cases. So, and these are, I promised you, I start with very simple things, and maybe in the next part, around lunchtime, we will do it more intensive, okay? So whenever I do an MRI of the breast, I talk to you now how to interpret and how to find cancer. So that's very simple. There you have this native scan. This is the before contrast. Then we inject the contrast. You see this is 1 minute, 3 minutes, 5 minutes. By the way, have you heard about this new hype on abbreviation protocols? Abbreviation MRI? So this is abbreviation MRI. By the way, Europeans do this since 20 years. Okay? So you only have to give a new name in an old product and you can sell it better. Okay? The same with Coca-Cola. If you do not sell Coca-Cola anymore, you say zero Coca-Cola. You do less sugar and you increase. This the same with abbreviation protocols. Julia, you agree? She's very in abbreviation protocols. No, because I just heard yesterday, we can discuss this on abbreviation protocols and the super acrin trial, and I learned that everything is related to money. So, because they want to do more MRI scans for the same money, and therefore they invented this abbreviation protocol. So, to do more screening cases, which is, by the way, good. But now let's go back. You have a contrast. You search most likely on the first post-MRI scan, where are the lesions? You see the lesion, you depict them, and then you judge. Very simple. When you are a superstar in ultrasound and mammography, you know what is benign and what is malignant based on morphology. Okay? If something is round, it's good. And if it is well circumscribed, we say it is good. If it is spiculated, indistinct, we say it's bad. Okay? Very simple. Use the same for MRI. Nevertheless, because we inject contrast, you have to focus now on this line. So, unfortunately, you cannot. So, if you see a so-called rim enhancement, outer rim, it's very indicative that this is a cancer. Very important to know. Also, if you see indistinct lesion with a rim enhancement, you can already say it's a cancer. On the other hand, if you have a nice well-shaped lesion and you can see non-enhancing septors. These are these lines. So where are you? Here and here. This is a fibroadenoma, most likely. So only to make it very simple. With other words, we always put together shape, margin, a little bit of kinetics, and you can differentiate between good and bad. So these are, what I showed you now is on this slide. Round, well circumscribed, good. Indistinct, irregular, heterogeneous, rim enhancement, bad. Good is benign, bad is malignant. Good is Peyrots 2, bad is Peyrots 4 and 5, because we need biopsy. Okay? Also very important, I will touch later, but you have to hear it. When you report on MRI, you have to learn that there are two types of lesions, mass lesions and so-called non-mass enhancing areas. Very important, because these non-mass enhancing areas, you have to describe them to find ductal cancer in situ with MRI. It's a little bit complicated, but there is a rule, a very simple rule. If the enhancement is not symmetric, as with other words, this is not seen in both breasts, as like here, and you see it only on one part of the breast, on one side, it's most likely that this is a non-mass enhancement. So let's do the first case. Very simple. One image, T2 weighted. First question. Is this a cancer, a fibroadenoma, a cyst, a fat necrosis, or abscess? Cyst. Who is for a cyst? What's about the Argentine doctor? You are not for a cyst. So, okay. I caught him, you see? That's interactive learning. Congratulations, cyst. Which Peyrots? Perfetto. Case 2. Native, dynamic 1, dynamic 2. Okay? What's that? Cancer, fibroadenoma, cyst, fat necrosis, abscess. Very good. See? Why is it a fibroadenoma? Well circumscribed, there is the ball in the breast, and you have a lot of non-mass enhancing septors. Very good. Which Peyrots? Now we are starting discussion. Is it 2 or 3? I know always, I said this is 2, okay? But of course, if you see it first, you can of course say that this is Peyrots 3, and you can then do ultrasound. So next case, one image. Everyone for cancer? Even Argentine? Yes. Yeah. Very good. Which Peyrots? Perfect. You see, very simple. That's MRI. You can teach it within 5 minutes. Success rate, 100%. No false positives. Case 4. Now it starts a little bit getting difficult. You see a T1 without contrast, a T1 after contrast, it's completely black, and you see a fat suppressed image of the same lesion. I tell you, the patient had surgery. So, what is your diagnosis? Very good, fat necrosis. And which Peyrots? 2. See? MRI is simple. Next case. And by the way, we are very fast. I tell you, we did now within 5 minutes 6 cases. Good income. How much do you ask for one MRI in Mexico? $500? No. In 6 minutes, in 5 minutes, 6 cases, 6 by 5, good money. I come to Mexico. So, next case. Also, there are 2 lesions, but they are very identical. You see contrast, abbreviation protocol, only 1 image. You see the curve, enhancing. So, what is now? Pirates 2, 3, 4, 5, 1. Is it first? Is it a ball or is it indistinct? It's a ball. Do you see septors? You have to look for the septors. There are thousands of septors here. Here. Everywhere are septors. So, it is a ball, you see septors, you say Pirates 2. It's no biopsy. Very good. So, what is the histology? Fibroid. Oh, perfect. Very simple. 2 fibroadenomas, okay? I know it's not so simple, but you see, I want to teach you. Next case. A woman, you know, she has an MRI scan, you see a native, you see the first dynamic. We see that there is a lot of contrast in the body because the vessels are getting wide. So, and you see differences between the right and the left breast. Have a focus on all the differences, and then you count together 1 and 1. So, what is one of the differences? Size. One breast is small, other is big. So, do you see another difference, maybe on the contrast? There is one is very strong enhancing, okay? Do you see, if you have a closer look, do you see a change if you have a look here? What's about the skin? The skin here is very thick, and the skin is enhancing partly. So, next question, what is your pirates? Okay, 4 or 5, no problems, we want to do a biopsy. Okay? Very important. And what is your diagnosis? It is cancer inflammation. Very good. You can imagine this woman, huge, changes in the skin, the readiness of the skin. Very important. Very good. Great job. Julia, you tell me when I have to stop, okay? So next case. T1 weighted image, before and after contrast media application. Okay? You see the difference? Okay. This is a sagittal T1 fat set after contrast media application. Also. And we go slice by slice through the areas. Okay? What is your pirates? 5, very good. Why? Here are the enlarged lymph nodes. Okay? Here is the cancer. Yeah? And here is the skin. Pirates 5. So, what is your diagnosis? 1, 2, 3, 4, 5. 1, hopefully. So, someone may say this is an abscess. In this case, not. This is not an abscess. This is a cancer. So, but tell me now, based on morphology, how will this tumor respond in neoadjuvant chemotherapy? Good or bad? Very good, because it is a ball, okay? If it like fingers, it's not good. Ball, good. Very good. So, next case. This is a stir image of the lesion, okay? I show you this is without contrast already. So this is a tiny little lesion, 1 centimeter, 1.5 centimeter in diameter. You have to look on the margins, okay? Here, particular here, and here. And here is the contrast scan. That's the lesion, how it behaves before and after contrast media application. This is the curve. Now the question. Again, take into account contrast and morphology on this image. Which pirates? Very good. Very, very good. Very important, or even 5, it's no problem. Okay? We need biopsy. Why? You see some indistinct areas, speculations, even on morphology without any contrast, it's pirates. So, what would you expect from histology? Mucinous cancer. And why? On the stir, it's bright. That means there's a lot of water inside, and that's the reason why it's bright. By the way, if you see this lesion, and they want to do neoadjuvant chemotherapy, what would you predict with respect to treatment response? Good or bad? All? Good. 100%. So, case 9. I have tons of cases. We can speak 2 hours. Aha, okay. So, I can entertain them until... but then you have to bring me some coffee. Case 9. T1 weighted image. Before and after contrast media application. Which pirates? Careful. This is T1 before contrast. T1 before contrast. There is no contrast in. What do you see here? Ducts. Think on the brain. What is bright on T1? Blood. So, this is not pirates 5, this is pirates 2, because I explain why we did next. This is now the reason, or let's say, what is your... She has a galactoreux, and we examined this. It was a little bit like milk, and the milk is protein rich, and that's the reason why it's T1. Maybe you have to be careful if it is a bloody nipple discharge, then it's different, and then you have to, of course, do some additional exams, whatever. And also what is important to demonstrate here, that she had no enhancement, yeah, which is also very good. Can we do a last case? Julia, one last case. Case 10. Contrast media application before and afterwards. Okay? One breast only. Focus on this area. This area, I enlarged it. What would you expect on histology? Very good. It's a non-mass enhancement, DCIS, excellent. Perfect. So, which pirates? 4 or 5. Very good. We need a biopsy. We need a biopsy. Perfect. So, yeah, you're ready for the second cases. So I appreciate if you are here around lunchtime. Many thanks for your attention.